Hello, and thank you for checking out First Call ID, Approach to Patients with Non-Resolving Pneumonia. My name is Paul Bunce, and I'm a physician in adult infectious diseases and internal medicine. We'll be spending about the next 10 minutes going over some of the key aspects of an infectious diseases consultation for patients who have a non-resolving pneumonia. If you haven't had a chance to do so already, please check out our initial video on how to do an infectious diseases consultation, which covers a lot of the basics of ID consultations in general, whereas this particular session really focuses on the specifics of pneumonia and patients who are not responding to therapy as we'd hoped to. Lastly, before we get started, just a quick note that this content is for educational purposes only, so please refer to current guidelines and use professional judgment in your own clinical practice. So here are the key points to our assessment as ID consultants and patients who have a non-resolving pneumonia. I like to include the past medical history up front, thinking about potential immunocompromise or immunosuppression and any history of pulmonary disease. We want to establish the patient's clinical course both before starting antibiotics and after starting empiric therapy. We'll take a detailed exposure history. We'll examine the patient for both pulmonary findings as well as extrapulmonary manifestations of disease. We'll review the investigations to date, including microbiology and imaging, as well as other testing. And from this, we'll come up with our impression and recommendations. So here's a framework that I have used for a lot of non-resolving infections in general. This is specific to non-resolving pneumonia. And in patients with non-resolving infections, I like to group things into the potential causes into 5 main categories. The first is drug-bug mismatch. Does the empiric therapy actually cover the pathogen? And this can be an issue with drug resistance or maybe inappropriate choice of the initial empiric antibiotics. The next category is, does the drug actually get to the site of the infection in an adequate concentration to kill the organism? The next is complications of the infection, and with pneumonia or non-resolving pneumonia, we can think especially of pulmonary abscesses or parapneumotic or complicated parapneumotic effusions or other metastatic seeding. We might have the diagnosis wrong, so non-infectious causes of pulmonary infiltrates, there are many, including malignant, autoimmune, and other causes. And then lastly, is it just that we're too impatient and we want patients to get better as soon as we click the order in the computer? And maybe they are responding, but just not quite as fast as we would like to see. Underneath each category, I've given some examples specific to patients with non-resolving pneumonia. I think if you're interested, just pause the video and take a look at these. They're a pretty comprehensive list, and maybe not everyone is relevant to a particular patient, but at least things to consider when you're assessing these patients. So starting off, we'll review the patient's past medical history. Is there any underlying immunocompromise or immunosuppression that could alter the typical flora that would cause pulmonary infections? We want to know if they have any history of pulmonary disease, do they have any structural lung disease, or any history of previous infections in the lungs. And then other conditions that could predispose to or have associated pulmonary symptoms. So anything that could lead to an increased risk of aspiration or other complications with the lungs, or systemic diseases that could have pulmonary manifestations. The clinical course is really valuable, and like I said before, you want to focus on what is their course prior to starting therapy, as well as since they start therapy. So when did the symptoms start? How have they proceeded over time? Any associated symptoms, aggravating or alleviating factors, right? So you want to get a sense of what's been going on before and how long has this really been brewing. And since they started therapy, how have things evolved? Have their symptoms changed? Have some things improved, but not all of their symptoms? Really, so you want to characterize, is there a partial response or no response at all? Again, you want to pay attention to the previous therapies and where they adhere to them as well. Exposure history is extremely valuable. For some, this is the heart of the ID assessment, especially with non-resolving infections. I think sometimes the exposure history can distract from the story in some cases, but I think it's important to still gather this information and keep it in mind, especially when patients are not improving, though they would be like them to. And so before this, we think about epidemiology and travel. So where have people been in the world? What have they been exposed to? We think about environmental and occupational exposures, especially animals, livestock, soil, and water. Healthcare exposures, right? So increasing the risk of colonization with drug-resistant pathogens. If they've had any procedures, could they have an aspiration event or a complication from the procedure itself? And then social and behavioral things such as smoking, recreational drug use, and injection drug use. Our examination will look at the severity of illness, how sick is the person, vital signs, and monitoring their vital signs over time, and their other parameters to see if they've actually shown improvement over time since starting therapy especially. We'll do a very focused or detailed pulmonary examination, And then examining for extrapulmonary manifestations of disease, again, for any metastatic complications or other systemic illnesses that can manifest with pulmonary pathology. So there's a lot we can gather from the investigations we have available, usually at the time of consultation. So we can look at the basic blood work and see if there's any biochemical evidence of improvement or worsening. Has there been any relevant microbiological studies that could shed light on the case? And what hasn't been sent or evaluated for that could explain things? The imaging is extremely helpful, if nothing else than to rule out some of the considerations. But personally, I find CT imaging of the chest extremely helpful, especially if it wasn't done up front, and sometimes after a reasonable period of time to assess for any progression of disease. I look for evidence of the pneumonia or pneumonitis and the pattern of infiltrate if it's present. I also pay particular attention to the development or presence of pulmonary abscess and pneumonic effusions. And pneumonic effusions especially to see if they're dependent or showing signs of organization, which could be an explanation for the patient's not responding to therapy. Occasionally, we'll look into some additional testing for other infectious, autoimmune, malignant, or other processes as well. So from all of this, we'll provide our impression and recommendations. And from the list of potential causes for a non-resolving pneumonia, we'll pick the most likely or the most important ones that we wouldn't want to miss and highlight those at the top of our list. We'll make some advice on antibiotic therapy. Do we need to escalate or adjust or tailor therapy at this point? Or do we leave well enough alone and continue to follow up our investigations? And we will recommend further investigations, those that are not available or that haven't been performed, that I've mentioned previously. And at this point, I'll often make an explicit statement of whether I think there's a value in pursuing bronchoscopy. Note that I don't say patient will have a bronchoscopy or needs bronchoscopy because I'm not a respirologist and I'm not the one who does the procedure, but I'll at least comment on my perceived value of this and whether it's worth involving respirology. So here are the key points, again, for our clinical assessment of patients with non-resolving pneumonia. And as I leave this up, I think I want to highlight again that the importance of our assessment is to focus on the most likely or important causes for a patient's failure to respond to empiric therapy. It's important to have a comprehensive list of potential explanations, but anyone can sort of Google or look up a list of possible explanations and copy and paste that into your note. Our job is to use our experience, our expertise, and judgment, and the available information to guide the next steps in evaluation and management. And lastly, it goes almost without saying, but it is extremely valuable to engage in discussion with our colleagues from respirology and medical imaging when we're assessing these patients, perhaps other specialties as well. We all have our own lens with how we view these cases, and I think it's really valuable to share our views and perspectives to come up with the best plan for a particular patient. So here are a couple of references that I think are helpful. The first is a general review on non-infectious mimics of community-acquired pneumonia, as that is a common cause of patients not responding to antibiotics when we presume that they have a pneumonia. There are several references on this topic, and this one's a particularly clear one. The next is what I call a classic, in my mind, review from Clinical Infectious Diseases on the topic of pneumonic effusions. I'll say it's a must read for anyone interested in ID or who's in ID or even in general medicine or who's going to see patients with pneumonia or non-resolving pneumonia. So that's all for now. I'm Dr. Paul Bunce, and I want to thank you again for watching. Please share any feedback you have about the session or First Call ID as a whole. If you like what we're doing, share, tell a friend, and if you can, share this with your trainees as a teaching tool. Take care, everyone.